Hi, everybody. We're going to get started, right? We're good, Lizzie? Yeah?
Yep, we're all set.
Okay, so we're really, really lucky to have two of the most busy people on Earth and also two of the most fabulous people on Earth to answer questions about the COVID-19 vaccine. I have the great honor of introducing first Dr. Melissa Stockwell, who's the chief of the Division of Child and Adolescent Health and an associate professor of pediatrics and population and family health. She's the founding director of the Department of Pediatrics Center for Children's Digital Health Research. She's medical director of the NewYork-Presbyterian Hospital Immunization Registry. She's a pediatrician in New York Presbyterian Hospital-associated community clinic and is associate director of the American Academy of Pediatrics, Pediatric Research and Office Settings, Practice-Based Research Network. Her own work is on underserved children and adolescents. She looks at translational interventions to improve vaccinations with an emphasis on health technology and health literacy. She is on-site PI for two large CDC community cohort surveillance studies for COVID-19 and co-chair of the CUIMC COVID-19 Vaccine Committee. You can see all the reasons she's in demand, so thank you for giving us your time today. Similarly, we have Dr. Marina Catalazzi, whose pronouns are she, her, hers, is an associate professor of pediatrics at the Vagelos College of Physicians and Surgeons and of Population and Family Health with us. She's vice chair for education in the Department of Pediatrics. She has served as the pediatric clerkship director and the director of pediatric medical student education at the College of Physicians and Surgeons since 2016. She's the track director for the medical education scholarly projects at the medical school. With Mailman, she's director of the general public health program, which is the largest accelerated MPH program in the whole school. And she's co-leader of the Sexuality, Sexual and Reproductive Health Certificate. Her research focuses on adolescent and young adult access to confidential and clinical preventive services, adolescent relationship violence, adolescent and parent communication and decision-making in clinical trial participation, and adolescent pregnancy prevention. She is an adolescent medicine specialist and is board certified in pediatrics and adolescent medicine. She does so many things. She runs an adolescent medicine practice in Washington Heights, and she is faculty co-chair for the COVID-19 Student Service Corps, which has been amazing. I'm sure you all know about it, and is now running a volunteer effort at the Armory. So thank you. Thanks to both of you for taking the time, and I'll hand it over to you.
Great. Melissa, we can't hear you.
Sorry. It's like now taking up my entire screen, so I can't find the buttons for the mute. Thank you guys so much for having us here today. I think our plan is to kind of go through some basics, and then talk a little bit about vaccine hesitancy and outreach, and then answer some common questions, and then kind of open it up. So I'm gonna be the clicker for Marina, so she's gonna tell me next.
Great. There's something about the slides where I can't see the whole thing. Can everybody see the whole slide?
Oh,
yeah.
Now you can't?
No, we only seen the end is cut off.
That's weird. All right, I don't know what is going on with my.
There we go.
There it is.
There it is.
Yeah, now you can see it?
Perfect.
I don't know what is going on. All right. Tell me if it goes back to a bad view, let me know. Okay.
Great. So we are really excited to talk with you today for several reasons. First of all, Melissa and I have worked closely together for the duration of our careers here at Columbia, and have actually given this talk in different settings before. But as we tell so many people, public health is such a critical piece of really being able to manage and overcome COVID. And I in particular have been just so incredibly moved by faculty, staff, student efforts, both locally, nationally, and globally in all of this work. So as we know, COVID-19, just to give you some of the epidemiology, which I know you're aware of, there's over 105 million confirmed deaths, confirmed cases globally, with 2.3 million reported deaths globally. In the US, unfortunately, we have a big number of those, over 26 million confirmed cases, over 455,000 reported deaths and counting. Just was on some operations calls with the hospital this morning, and we really still are seeing, patients, both adult and pediatric, within the system. And in New York City, we have felt a huge brunt with over 637,000 total cases and over 27,000 reported deaths. So, this has certainly hit close to home. I know that those of you who have heard me speak before, I really like to think about the vaccine in terms of not herd immunity, because we are not cows, but community immunity. And I think this is incredibly important, particularly right now as we're talking about choices to get vaccinated and the support of the vaccine efforts. If large enough numbers of people are vaccinated, we can really block widespread infection. I think that's going to be particularly important as we're seeing some of the variants that may be more infectious, and also hopefully covered by the vaccines that we are currently giving, Pfizer and Moderna. So if you look, just the basic concept of community immunity, which if nothing else from this talk, if you start talking about community immunity, I will be delighted, because I think it's really important to think of who are we in our community, and are we supporting the effort by getting the vaccine when it is our turn to get it. So if you're not immunized but healthy, and you have someone who's not immunized, sick, and contagious, you can see a disease that's very contagious is going to spread throughout the population. And this is what was happening in New York City in March and April, and that's why we saw such incredibly high rates. If you are not immunized but still healthy, you have a couple of sick, contagious people, and just a few people are immunized and healthy, it's better, but not good enough, right? And the idea here is that we were trying to immunize first healthcare workers, really the most vulnerable, those who are over 65, those who we've seen really hit by the pandemic in underrepresented communities who are over 65 as well. You can see in the third panel there that if most of the population is getting immunized, you're just going to have very little spread because those who are healthy are just not going to get as sick. And this is what our hope is, right? This is the kind of how do we get back to some semblance of life as we knew it pre-COVID. Things will never be the same as pre-COVID, but certainly we need to get to a place where enough people are immunized that we're really not having the rate of spread that we're currently seeing. So this community immunity is something that we really need to have people who we are talking to and communicating with, CBOs, other partners, really be part of and take ownership of as a member of their community. So what we've seen over the last few weeks and months is this unprecedented coordinated global effort that really has let us develop this vaccine so quickly. But I think one of the things that I think is incredibly important to get across is that this foundation has been laid over 50 years. So an mRNA vaccine technology has been going on for the duration of my medical career, for sure. And I remember when I was at CHOP that there was discussions about development of mRNA vaccine technology, and particularly because of the the SARS in 2003 and MERS epidemics in 2012, the idea of targeting the spike proteins, when you see those beautiful pictures of COVID with the spikes coming out, that really that idea was developed with SARS and with MERS before of it. And then because of the emergency, we really have been able to ramp things up. So just looking at where we were in 2020, so both Pfizer and BioNTech got their joint SARS-CoV-2 vaccine approved less than 8 months after the trial started because of the ability to overlap, not and because they didn't see any safety concerns, but every single phase was hit and nothing was cut. There were no corners cut. And I think just to get across that because of the foundation that was laid and following all the steps. So here in January 2020, the COVID-2 genome was released and some preclinical studies started. Between April and May, they were able to start the phase 1 and 2 clinical trials. really between July and August, phase 2 and 3. And here you see rolling out data to regulators, and then in December, countries starting to approve for emergency use, which is what everyone is really acting under now, this emergency use. So how do vaccines work? So those of you who've been working with me at the Armory know that I have been talking about this, which Melissa has gotten across. And it's a combination of ways that I used to describe it and ways now. So it's almost like having a wanted poster, right? So the vaccine is working by showing your immune system what a piece of the coronavirus would look like. And this wanted poster, right, is a really good thing. So mRNA is basically a picture of part of the virus, so that the little army of antibodies starts to be able to recognize it. And what I've been saying is that second shot, that booster, right, is basically showing it to you again, so you're really clear and you can get even more of your immune system, even more of the kind of those folks who are part of that army to protect you, to get it together, so that if the real coronavirus, not a picture, but if the real coronavirus ever tries to enter your body, it's going to be recognized and attacked by immune cell and antibodies. And so for me, that's been really helpful when we talk about mRNA, to not confuse it with DNA and getting into your cells, but really here's this mugshot, this wanted poster, and it's going to be recognized as coronavirus. And when you actually see coronavirus or these beautiful little spikes here, that is what your body would be responding to. So take that as you like to adjust it, but I think it's really helpful to describe it that way. So both Pfizer and Moderna are mRNA vaccines. mRNA is basically this blueprint for making proteins. And here it's going to be making a protein against the spike protein on SARS-CoV-2. It is not infectious. So that's a really critical piece, that we're not giving a piece of the virus. We're not giving any virus, really. And it cannot integrate into your cells, and there's really no potential for infection. As opposed to, live, people have heard about live virus vaccines, and there's or killed virus vaccines. This is really very different in that it really is just messenger RNA making a blueprint for a part of the protein of the virus. mRNA is disposed of naturally, so it's naturally degradable, and there's no anti-vector immunity, as you see with some of the other vaccines like the adenovirus vector vaccine. So I think that's just some basics that are helpful to see. I think really what has been, most effective in counseling folks who are thinking about getting it is just the remarkable efficacy that we've seen. So that is what is the response, the immune response, the antibody response that we've seen with Pfizer and Moderna. And so when people kind of come in and say like, oh, I wanted Moderna because Fauci got it, well, look at Pfizer, 2 doses, 21 days apart, currently only authorized for those over 16. We're hoping we're going to be able to go lower in ages once we get all of that data. But this was based on nearly 44,000 participants. There was 95% efficacy in terms of response, immune response to vaccine. With Moderna, 2 doses, 28 days apart. This one is only authorized for those over 18. Again, it just depended who was in those studies. About 30,000 people, 94.1% efficacy. So again, really, whatever people can, when they're eligible, whatever is being given that day, that's the second dose they will get as well. But really just supporting that the evidence shows that both have the same efficacy after the second dose. And just a little bit more about vaccine safety. So one of the important pieces, I think, as all of us are very, very unfortunately aware, is that just the disparities in infection and death really has so much to do with the social determinants of health, right? So who is working as a frontline worker, where people live, how they have to get to their jobs on mass transport, et cetera, living in more urban areas, et cetera, has really made a big difference. And that's why we've seen community of color just communities of color just hit so hard. And what we know from the trials is that they really tried to represent those who were also being infected. So really making sure that this was addressed, and so that we saw efficacy in all of these populations. So the trials were really tens of thousands of adults, diverse backgrounds, including older adults and communities of color, and 30% were US participants. The COVID-19 vaccines really are being held to the same safety standards as all vaccines. Again, as we talked about before, it was overlapping steps, none skipped. And one example of this is that instead of waiting until after all the testing was done to start manufacturing, they made the vaccine while it was being tested so that they would have a supply starting right away. And even with that, as we know, supply has been an issue, but that is something that hopefully can reassure folks. I think I'm still going, right, Melissa? So,
yeah, you're still going.
Yeah. So just, we wanted to talk a little bit about some of the side effects of the vaccine, because I think this is also really, when you talk about vaccine hesitancy or anticipatory guidance, and this is something, so Melissa and I remember are pediatricians in primary care and adolescent medicine. And so we talk about vaccines a lot, and it is important for people to ask questions. And we really encourage that. And really, you know, in one of the things we do in pediatrics is give a lot of anticipatory guidance prior to someone's appointment so that they know and they can read up and we can give them the information. But it is also important to give anticipatory guidance and real numbers about what the side effects are. So what the reality is that some people have no reaction to this vaccine in particular, the COVID vaccine in particular, and others do have symptoms. And it's difficult to predict, like, oh yeah, when I get the flu shot, my arm is, it's really difficult to predict. And part of it is just how your body is building immunity. If you don't have symptoms, it doesn't mean that your body isn't building immunity, but if you do, it's just kind of giving you an external sign that it is. The most commonly reported reaction, and one important thing is when and if you do get the vaccine, there is a way to sign up, and we'll tell you about that, to be able to report what symptoms you're having, because we do want to completely continue to be able to tell people what the most common reactions are. But the most common thing is just soreness at the injection site. So we usually tell people to use their non-dominant arm because you get it in the deltoid. The next most common are fatigue, headache, muscle aches, joint aches, and fever is less common, though can happen. Most people are finding that reactions are more common with the second dose. And I will just tell you my experience. I got Pfizer. I got it on the day before Christmas Eve. And on Christmas Eve, I had a really bad migraine. I had to rest. I had a really sore arm, and I never take a nap. And I took a nap, and I took some Motrin. And after the second, which was, I think the day before MLK weekend, my second dose, I actually had just more soreness, but I also was working at the Armory that night. And I felt okay. I was just tired, but I didn't have a headache. I have heard all sorts of things from colleagues, you know, people who've had fever and chills and had nothing at all. You know, it really varies a lot, but it's really important to know that this could happen. And as long as you're not having respiratory symptoms or cough or difficulty breathing, those are things that you shouldn't get with a vaccine. And if you have symptoms of COVID, people should still, because you can get COVID when you're in between dose 1 and 2, or even right before dose 1. For most people, these side effects are not going to last more than 24 to 48 hours. Tylenol, anti-inflammatories, if people can take them, if they're okay with other medical issues, are fine. We don't suggest pre-medicating because we don't want to dampen the immune response before you get the vaccine. So that's really just important to remember, because you know, sometimes people think like, well, if I get it first, it won't hurt as much going in, or I'll have an easier time, but we want to avoid that. And with any medicine, allergies can happen, and you've likely read a lot about this, and so we'll talk about this a little bit. Even so, they're quite rare. I have actually not seen any allergic reactions in all of the shifts that I've done at the Armory. Here's just a really nice comparison chart of you know, some other vaccines that we know well. So here's Shingrix. If anybody has gotten it, is for shingles. For those of you who've had chickenpox in the past, here's Moderna and Pfizer, and here's the quadrivalent flu vaccine, which is now available. So if you look at local pain, it's really similar to Shingrix, a little higher than flu, redness lower than these others, swelling, myalgias right around the same as Shingrix and definitely higher than Fluvax, fatigue. So this just helps, I think, just if you look at it overall, because this is not new. Vaccines cause side effects. We know that this happens. We know it's your immune system ramping up. And it just, I think we talk about these more now because we have a mass vaccination, right? We are trying to get everyone yellow, right? We're trying to get everyone into that range of people who are vaccinated so they won't be able to get infected by someone who's infectious. And to get that community immunity, we have to make this big push. And so it gets us talking about it more, but do want you to be aware that there are side effects with many vaccines.
Great. So hopefully we've now done a big, quick primer on all things COVID vaccine. I'm just going to tell you a bit about logistics, then kind of move into vaccine hesitancy. So where are we in New York State right now? So as you remember, in mid-December, we started with phase 1A, which were healthcare workers, long-term care facility residents, and then some other groups that were related. Then we moved into phase 1B in January, teachers and education workers, first responders, public safety workers, public transit workers, those who 75 and older, and this became quickly 65 and older. And then Governor Cuomo had mentioned adding those who are immunocompromised, but had not yet defined with the CDC what that would be. What just came out is that as of February 15th, there is a new and expanded phase. It's really 1B, 1C, which is kind of all of these differing chronic medical conditions. I know, sorry, the type is small. I couldn't get it to be, I guess, big as I could for the slide, but basically cancer, kidney disease, pulmonary disease, intellectual developmental disabilities, heart conditions, immunocompromised, severe obesity, pregnancy, sickle cell disease, type 1 and 2 diabetes, cerebrovascular diseases, other neurological conditions, and liver disease. And then they say this list is subject to change based on emerging evidence. So there are now quite a large number of New Yorkers who will be, as of February 15th, be eligible to be vaccinated. And that will increase this number of people who are vaccinated in the US by quite a lot. Currently, there have been 31.5 million people in the US who received one dose and 9.1 million who've received 2 doses. Although there will be a lot of people who are eligible, obviously we know that there has been an issue with access for even those who are currently eligible. So New York City and New York State both have websites. This is the New York City one, where people who are eligible can go, fill out information, and then sign up for an appointment online. It isn't, I'm not going to lie to you, it's not a great site. And then it's not that you put your information in once and it tells you where all the places are that are open. You really have to kind of go site by site. So it is quite a lot of work to find a place. There are some massive sites that are being opened. So for example, Yankee Stadium just was open. I believe it's Somos that's the one who's giving the vaccines there. So people who live in are residents of the Bronx, that is open to them. And my understanding that they have quite a number of appointments. There are a lot of appointments around Manhattan, but again, it's a little bit of searching for which one that has been particularly difficult. Our current site, the Armory, is still 65 and older. I know a lot of questions about whether ultimately other 1B will be able to go there. That still has not been, we get our orders from New York State, and so that has not been changed for us yet. So currently Armory is 1B in New York, only those 65 and older in New York City, with a preference for those who live in Washington Heights, Harlem, and the Bronx. So in order to reach this community immunity that Marina mentioned, we really do have to tackle this question of vaccine hesitancy. And so we know that this is an issue for COVID-19 vaccine, but has also been changing a bit over time. So this is from the Kaiser Family Foundation. This was tracking, they did a lot of this tracking. This particular tracking was end of November to early December. You can see that people were asked, if the COVID-19 vaccine was determined to be safe by scientists and available free for everyone, would you probably not get it or definitely not get it? that's 27% of everybody, and then it obviously has changes very differently based on different demographics. So while this idea of vaccine hesitancy, is potentially new to various groups, it's something that we in pediatrics have been thinking about for many, many years, as Marina mentioned. And so there's, I think, a lot of lessons that can be learned from what we know. So the first is that we really think of vaccine hesitancy as a spectrum. And that means that if you're looking across different vaccines, sometimes people will accept all vaccines, sometimes will accept some, delay some, refuse some, sometimes refuse all. And that can be different. We talk about being different in place and context. So for example, someone might be very accepting a flu vaccine and Shingrix, for example, but not with the COVID vaccine, or we know a lot about not wearing the flu vaccine, or no matter, or on the other hand, might want every vaccine as soon as possible. So we really have to think of this as a spectrum, but also that's something where people are potentially, can be moved across the spectrum as they get their questions answered, they feel more comfortable, that people aren't static around vaccine hesitancy for the most part. And there are a lot of different models around vaccine hesitancy. This is a very common one from the WHO, from the SAGE group, which is called the 3 Cs. And if you, for those of you who know the health belief model, which most of you do, this will be very reminiscent of the health belief model, which actually works incredibly well for vaccination. So the first C is complacency. So if someone doesn't perceive a need for the vaccine, or they don't value the vaccine, then they're not going to get it. That makes a lot of sense, right? If you don't think that you're at risk of COVID, or you don't think that COVID-19 is dangerous, you think it's just a mild infection, then you might not want to be vaccinated. And similarly, if you don't think the vaccine has value to you, you won't be vaccinated. Times that is obviously confidence. If you don't trust the vaccine is effective, you don't think it's safe, but even more so, if you don't trust the healthcare provider, or the public health system, or the place you're getting vaccinated, then that will tip some potentially to be more vaccine hesitant, which makes a lot of sense. So I'm going to unpack that a little bit more on the next slide. And then finally, convenience. So it has to be available, affordable, accessible. As I just mentioned, we haven't necessarily made it, not we, but it has not been as accessible as we would ideally want it to be. And so all of these 3 things are very much in play with the vaccine. So kind of digging a little bit deeper into the SAGE model of what were the influences of vaccine hesitancy. And again, the focus has primarily been around parents and pediatric vaccines, but you can see really all of these are very much playing a role in COVID as well. So the first order individual or social group influences. So, what's the social norm? Is it that something where is seen as needed, or it's something that's seen as harmful? What are a person's beliefs and attitudes and motivations around vaccination, their knowledge or awareness, but also what are their personal experience with the medical system? How much do you trust the person who's encouraging you to get this vaccine? And then what are the risk benefits? These are perceived risk benefits, so not the scientific ones, but what do you feel like your risk is of COVID? What do you feel like your risk of getting the vaccine, or the benefits of the vaccine? And then what's your experience with past vaccinations? So have you had good experiences versus negative experiences? But what's talked about a lot, and I think in public health, this is going to be obviously not news to you, is that context matters as well. So who are the influential leaders and individuals in the community who are talking about the vaccine, either in a pro-vaccine way or an anti-vaccine way? What are the politics? Part of this has been very hard to disentangle this from the politics of Operation Warp Speed and Trump. About religion and culture, there's different things around social media, particularly around the misperception that it's a DNA vaccine that will change your DNA, and that will change God's plan for you, and so that you can't be vaccinated because it changes your DNA. And so it's important to kind of understand some of the messages that are going on social media. There's different influences of different SES groups, communication in the media, the pharmaceutical industry, and previous history with it, and then historical influences, and particularly really, and I'm not saying anything anyone doesn't know, a horrific history in the public health and medical community of experimentation. And so there's a lot of very understandable reasons, particularly in Black and brown communities, of distrust of the industry, distrust of the medical community, distrust of the vaccine, and something that really needs to be understood as messengers about the vaccine and really helping people get the information again that they need, but also from trusted sources of people who they feel can give them the information. There can be geographic barriers, and then vaccine and vaccination specific issues. So what's the risk benefit, the scientific risk benefit? So for example, Marina went over the vaccine effectiveness from the trials. What's the vaccine schedule? In this case, it's 2 doses that are needed quite close together. How are we delivering it? Is it a new vaccine? Obviously it is. Reliability of supply. There's been this, unclear, who can get the vaccine? Is there enough vaccine? When can you get it? Or date? People who have appointments that are canceled. That's made it very complicated. Doctor recommendation, cost, so in this case it's free. And then sort of really tailoring the vaccine to the needs of people. So you can see that, well, this model was put together many years ago. It really does fit incredibly well for COVID-19 vaccine as well. I'm sorry for the blurriness. This is the slide that disappeared from my slide deck, got stripped out from the PowerPoint, so I quickly tried to put a new one in. But again, ultimately, if you want to move people towards vaccination, you have to know kind of what do people think and feel, what are the social processes that motivates them to be vaccinated, and there's the practical issues of can they actually get the vaccine, and that ultimately leads to vaccination. But these are really important conversations to have, because what we know from pediatrics and adolescent medicine is people, again, do change. So someone who's anti-vax for everything, you probably are not going to be able to change their mind. But for people who are vaccine hesitant, people do over time with conversations, do often get the information they need and make potentially decisions about being vaccinated. This is again from the Kaiser Family Foundation, asking the same question about would you definitely get it or not get it in September versus December, and in all overall plus in among Black, Hispanic, and white people who completed the survey, there's more people who would definitely get it and fewer who definitely or probably not get it over time. And that just shows that that's again, these are not, vaccine hesitancy isn't static, right? It's something that can change over time. So what do we, I'm realizing I didn't swap in the other slides, but what do we then do? So we talk a lot about, have been talking in pediatrics and now a lot in COVID-19 about motivational interviewing. So what does that mean? The idea is basically to have a kind of patient-centered, empathetic, and non-judgmental conversations with people to understand what is the information that they need, and then provide it for them. And so the idea is not to be counter-arguing, not to, first of all, do something, what would you call it, as a data dump, which is sort of these must be the 10 things you're worried about. So let me just tell you these 10 things, and then you're going to get vaccinated, right? That's not, as we know, the way to communicate with people in general, but in particularly not people who are vaccine hesitant. Another kind of pitfall is feeling like you're there to persuade them, right? You're there to, if they would just listen to you and get vaccinated. That again doesn't work in general for health behavior, but definitely doesn't work for vaccination. In fact, we know from really good and interesting studies that counter-arguing with those who are hesitant is actually not only unlikely to change their mind, but actually can be very likely to entrench their beliefs. So you actually can cause harm by kind of arguing and persuading. And while it's hard to do, the idea is to give information with the point of you're listening just to elicit, just to ask the questions and answer the questions they need to be asked without trying to persuade them. And again, that's kind of the crux of this motivational interviewing, and particularly helpful around these kinds of vaccine conversations. So some things, are considering affirming statements. So for example, saying, for someone who's concerned that the vaccine was developed in record time, I'd say, you're right. If the vaccine was developed in record time, let me explain, or often you would say, can I explain what I've learned about that? So a good part of interviewing is asking permission. Like, can I share with you? And someone say, no, I don't really want you to share with me. But usually I'll say, sure. And then you can say, I went to a talk, last Monday where, Dr. Pelasi talked about, these are the vaccine timeline, really, how it was developed, and that the steps weren't skipped. Or so I might say, look, I think over time I'll get the vaccine, but I don't want to be the first. I don't want to be the guinea pig. I want to see what happens for other people. And you can reflect, this is reflecting back to them. Here you're open to getting the vaccine and you'd like to wait and see what happens to folks who get it early. Well, here at Columbia or here in the country, this is the experience that we've had, and and have really not seen the side effects that we've seen have really been in line with the trials and haven't been seeing severe side effects. So those are kind of some of the quick snippet of communication tips around these conversations. So me and I thought that we would end by kind of going through some of the common worries that people might have, and then we'll kind of open it up for questions to be able to answer them for you. So I'll take the first one, which is, I've already been infected with COVID-19, so I don't need the vaccine. So this is actually something that we commonly hear, but the fact is that we also are starting to see reinfections of people who were previously infected with COVID and are now getting infected again. As Terry mentioned, I run a community surveillance study. We just had a family, our latest family, where a group of people ended up with COVID again. We're super surprised because they had COVID last spring. We think that there probably people have about 3 months of protection from infection, but it's really important that people still get vaccinated so that we can continue to protect them. The second one, Marina, you want to take the second one?
Sure. And this, so a lot of folks will worry that it contains a live virus, so it can give them COVID, as we talked about before. This is a messenger RNA. It's actually a very, we've heard, Melissa and I have been on calls where immunologists discuss it as this like beautifully simple. It's just really simple. Like there's some mRNA, there's some salts, the PEG, which is what people end up being allergic to. So really like 4 ingredients, but there is not live virus. And so you cannot get the infection. You can get an immune response, which doesn't feel good for a couple of days, but definitely not the infection itself.
The other newer one that we're hearing is I shouldn't get vaccinated because there are new strains that are out there, and so I should wait. There's still evidence that's being gathered about the protection against the new strains. I think for some of them, the vaccine is fully protective, as protective as the currently circulating strains. For some of them, it may offer less than 90% protection, but the protection that it offers is still more than no protection, right? And so we also have to remember back when we were thinking we would be ecstatic if only the vaccine covered 50%, right? If vaccine 50%, and then it was 90%, we were so amazed. So again, it's still 100% worth getting vaccinated. Will there be booster doses over time that cover new strains? There might be, there could be, but really we need to get everybody who's eligible vaccinated as fast as we can, because the other way to prevent new strains from emerging is to really, get that community immunity, right? Have fewer people who are at risk of infection, so that we can really kind of be able to start halting coronavirus in its tracks. The next one, Marina.
Yeah, and just to piggyback off of that, I feel like a lot of people will ask, how long will this last? And, the reality is we don't have all of those answers yet, right? We know, though, that the natural immunity doesn't necessarily last because people can get reinfected. And I've been talking about it like the flu vaccine, which is that every year you get a new flu vaccine because we kind of predict which flu variant there's going to be, right? So I think getting into the mindset of like, again, we're going to have to think about the future later, but first we have to stop the spread, and that's what's going to do it right now. And the reality is that it is likely that there will be, either people have tested about it as boosters, but I think about it as a flu vaccine, kind of following what the virus does. The vaccine alters my DNA. Again, similarly, it's a messenger RNA, does not make any changes to genetic material. Really, and again, because of all the historical pieces that Melissa talked about, that we all have to be aware of and really be able to acknowledge and address, but that is not the case in this case.
The other thing is that people think that once they're vaccinated, that means they no longer need to wear a mask or practice social distancing. And again, that isn't true. Even though someone's vaccinated, we really do need everybody to still take the same precautions. That's for a couple of reasons. The first is 95% effectiveness isn't 100%, so there's still that 5%. There is still, the original trials were not set up to answer the question about, is the vaccine protecting against symptomatic infection versus asymptomatic infection? And so that's still, we're not saying that it doesn't protect against that, but that wasn't what was studied. There's a little bit of evidence from the Moderna trial because they did swabs at this time of the second vaccine that there is some protection against asymptomatic infection, but again, we're waiting for studies that are particularly looking at that. And the third thing is that again, as we start to have these new strains, right, it's really going to be important that we are, continuing to practice all of these, masking and social distancing. And really that is, right now as good as a vaccine, right? Like that really, if we can get everybody to mask or social distancing and get everyone vaccinated as much as we can, we are going to be able to, hopefully turn the tide. Do you want me to take the allergy one?
Yeah, I'm okay taking it. I just want to say also that a lot of people ask about can it change their, I got a lot of well, now I'm going to be able to see my new granddaughter in California, and it really shouldn't change travel restriction behavior either. Everyone's going to make their own decisions about kind of how much risk they want to incur, right? Or whatever it is, or travel and the how you can be safer in travel. But just to say, I have not changed my behavior at all, right? So I got both doses. I, also have been coming to work daily during the pandemic, but everything for myself, for my family, I have not changed my behavior at all. And I think that is while, do I feel hope and did I feel joy getting the vaccine? I felt grateful, so many things, but I really haven't changed my behavior. And that's really hard right now. But I think that, again, we have to be in this in the long run, for the long run. Just the piece of vaccines because of allergies. So the only contraindication to getting the vaccine is if you have a allergic reaction to a component of the vaccine, PEG, which is also found in laxative Miralax. So people will usually know, or if there has been a severe allergic reaction to a vaccine in the past. And even with a severe allergic reaction to a vaccine in the past, if we know what vaccine and can understand it, you can still get it. So it's really the PEG allergy that's important. What the practice right now has been is that everyone gets observed after vaccination. If someone has a history of anaphylaxis to anything, these things, medications, they get observed for 30 minutes. Not because there is an overlap with the vaccine or that there's an expectation that they will have anaphylaxis, but really just to be as safe as possible. So I think that's really important and something that, again, everyone gets screened for all of these things, but that's an important piece to understand. And Melissa, I don't know if you have more to say about that.
No, that's the main thing. I think it's just that we, and even though early on we were sort of unclear what the increased risk of allergies were going to be, and in the end, for general vaccines, we think it's about 1 in a million doses, and for these vaccines, it might be 2, 4, 6 out of a million, right? So it's still very, 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 very rare. But as Marina said, we're being overly cautious. Everyone did 15 minutes. People with potential risk, they were 30 minutes. All the sites are set up, with EpiPens, whether it's the Armory or whether it's the drive-through, vaccinations in California. Everyone's really set up to care for this should it happen. But as Marina said, I don't want to knock on wood. We've been very fortunate. The other thing is that COVID vaccines can cause severe side effects. We really have not seen side effects that are different than what we've seen in the trial. So those first 30, 40,000 people, and that's really what we've been seeing. We have not been seeing severe side effects with the vaccine, and now there's been, as I mentioned, millions and millions and millions of people who have been vaccinated.
There has been a lot of concern around infertility or miscarriages, and Melissa and I have been closely in contact with our colleagues in OBGYN. And while the initial trials were not meant to include, it was not part of the inclusion criteria to have someone who was pregnant, the reality is that pregnant persons were included because they didn't know they were pregnant at the time, and there were no untoward effects. The counseling right now is that if you are on fertility treatment or planning to get pregnant, that you should get the vaccine beforehand, if it is possible, because it would be protective. There have been some very severe complications with COVID infection and pregnancy, not COVID vaccination. And so avoiding COVID infection is really important. We've had some very outspoken providers who have been breastfeeding, who have received the vaccination without any untoward effects. And it is, if someone is at risk of receiving COVID because of their job, because of the work they do, if they're an essential worker, if they are breastfeeding, they are given the opportunity to get the vaccination.
So I think we thought that we would kind of stop there with the slides and open it up to questions. I don't know if people want to put questions in the chat. Let's see. How best do you want to do it, Terry?
I'm not seeing any questions in the chat right now. Do you want to, can people put questions in the chat if you have them? That was really, really great. I see, what do we know about the vaccines, reduced transmission or viral load?
Yeah, that's what I was kind of alluding to, is we don't yet know what the effect of the vaccine would be, both on asymptomatic infection, but also on transmission. So for example, if I'm vaccinated, I am protected myself against symptomatic infection and either mild or severe. But what we don't know is, against kind of asymptomatic infections as well as transmission to other people. That being said, although there was, we've definitely been hearing people who say they don't want to get vaccinated because they'd rather get infected, know they have COVID, because I think that's safer for their families than being vaccinated. And I just kind of want to tease that apart a little bit. It's one I would say is that while there is definitely asymptomatic spread of COVID for sure, what we know more is that actually a lot of people who were thought to be asymptomatic are really pre-symptomatic. So what that means is, it's the couple of days before you become symptomatic. And that's certainly what we've been seeing actually in our COVID surveillance studies, really commonly. So we do weekly surveillance. We have 500 pregnant women and 450 household members, where some will turn positive on our weekly surveillance swab. It takes a couple of days for them to send it in, for the lab to run it, and we call them, and they didn't have symptoms when they took the swab, but by the time we call them that they do. So again, although for sure there is asymptomatic transmission or asymptomatic infection, a lot of it is pre-symptomatic or symptomatic. And that from the one kind of piece we have from the Moderna trial, there does seem to be a decrease potentially in actually asymptomatic infection. And then in general, the most protective is it's going to protect yourself from symptomatic infection. We also have a lot of transmission. It's much more likely and higher to actually within a household to infect somebody or other people. This is a lot of studies that were done in China if you are symptomatic. So again, what's safest for your household is actually for you to be vaccinated as well. And there are ongoing studies where we can answer this question potentially about asymptomatic infection. And ideally, we want to get to a place where there is vaccine available for everybody. There's vaccine available for kids as well. So similar to flu vaccine, where everybody can be vaccinated and themselves, protected for themselves.
So you see the next question, say something about the endpoints of the vaccine studies, mortality and disease severity. And also, I will say, when I was at the Armory, I kept being asked, will we have to get this vaccine every year?
Well, as Marina said, that remains to be seen. I think for the endpoints, so the endpoint of the two big trials was again symptomatic infection. So it wasn't just swab positive, and then they had symptomatic, just any infection, as well as severe infection. So again, sorry, my office outside the ambulance bay. Again, that for both of these vaccines was protective against both any infection as well as severe infection. For the current vaccine studies, and the hope again is that Johnson & Johnson/Janssen just submitted their packets to the FDA for their EUA, and which will more there's some snippets of information that's come out from press releases, but when that information goes to the FDA, we'll be able to see the FDA briefing documents from them, and we'll be able to understand a little bit more again about their efficacy both against any infection as well as severe infection as well. Marina, do you have anything to add to that?
No, I think that's great. Someone actually also asked, sent me directly, what's the current state of accepted treatments for those who are infected, and is there a universal protocol? So the treatments are for those who are infected and in high risk categories. So if an 80-year-old is infected but not symptomatic, for example, they can get monoclonal antibodies. And then the rest is really based on whether or not someone fits the criteria of admission. So for example, remdesivir is really used for those who are admitted and have are symptomatic, have oxygen requirements, et cetera. And then the rest is really, there's still a lot of ongoing trials right now. So I would say the two most fully accepted are monoclonal antibodies, and really trying to get those before someone gets sick or symptomatic, and then remdesivir for someone who is sick and symptomatic, plus other things.
Yeah, and just how Marina said, because I think people don't really know this. So once you get admitted, you don't qualify for monoclonal antibodies. So it's only when you're outpatient you get brought to the hospital to do the infusion for them. But really, it's for people who are high risk when they're outpatient before they're sick enough to get admitted. So that's I think important for people to know. And that is one reason why we delay the vaccine. If you did get monoclonal antibodies, and we do wait the 90 days before you're vaccinated again.
Okay, I think we only have 2 minutes left because I know Marina and I have to go on another call. But this one question, how should folks be if the gap between their two vaccine doses is longer than intended?
Yeah, so that's okay. We actually know a lot about 2 doses also from pediatric vaccines. So again, the clinical trials, they were trying to find the balance between what's the fastest to get to full protection, right? Because we know that you have your full protection 7 to 14 days after your second dose, but giving time for your immune system to reset enough between the doses that the second dose will act as its booster. So for Pfizer, they found that to be 21 days, for Moderna, 28 days. Again, if there is a delay because of supply issues, that's okay. You just come whenever it's again available. You come in and get vaccinated. That second dose will still give you the booster that you need. That being said, we also don't delay on your own, right? Like if you're due and they usually would set you up for an appointment. Come in and get it, because the idea is to get everyone to their full protection as fast as they can before they might encounter coronavirus.
Okay. I think, so thank you so much. Marina has put in the chat how you can volunteer, and we're getting lots and lots of thank yous. Thank you both from everybody for the work that you do, and there's hope thanks to folks like you. So.
And I would just like to put a plug for PopFam, because I started in my public health vaccination and all my training now many years ago as a student here in PopFam. So I came to do a primary care fellowship and did my master's in PopFam. So I say I owe all of this to PopFam and to many of the same faculty, including Linda Cushman, who taught me everything I know about survey design. So just a shout out to PopFam.
Thank you. Thank you. Marina, I'll see you in 1 minute.
Okay. And really, truly, if there's anything we can do for anyone in terms of information, slides, let us know, and we're happy to share anything.
Absolutely.
Thank you.
Thank you both so much. Thanks, everybody.